in Margaret.
Yeah, so actually what just wanted to say that in previous time, we were not in a position actually to sit with these platforms like the government, other agencies who are actually looking at us from the eye that of supporting. So I'm a KVP. So we are the KVP. We feel cheers to be with you guys and all people who have good intentions with us and the community at large. So we feel very good to be with you and to hear from you on what programs you're telling us, and also to listen, you guys listening to us on what contribution so far we need you to support. So I think me and my colleagues as KVP in Tanzania, we are proud of having these platforms, engaging with the government, knocking the doors of the government, the ministry level, and having the space to provide any technical support to colleagues, like the facilities where we are moving, and asking recommendations from the communities, what they want, and also representing these things to the government for decisions. So we feel cheers to be with the people that can be supportive, and we look forward for more collaborations. Thank you very much. That's what from my,
Thank you so much, Maroneas, for those wonderful words. I think you've really set the tone for the discussion today. It's about collaboration. It's about working together. It's about not leaving anyone behind. So without further ado, for the next 15 minutes or so, we're going to listen to our very own Margaret Kagashe, who has put a presentation together on the context and our experience in Tanzania in terms of addressing stigma and discrimination for people, for key and vulnerable populations. So over to you, Margaret, for the next 15 minutes. Karibu. Nakila laheri.
Thank you so much, Koech, and the whole team around, for those who are part of this meeting from different countries. Just appreciate the time and the moments. The presentation will be categorized in 3 areas, and I will start with the part of the government and the profile of the country and all around that. Then we'll hear from the implementing partners view. What do they do exactly to making sure the stigma and discrimination is being addressed? And the last part we'll hear from the KVP, the KPs themselves, what they see. We haven't reached there yet, but we have done a lot along the way. So to start with, this is the country profile. Tanzania has a population almost 55 million people, and almost 40% of those people are under 15. If we look at the prevalence of Tanzania, it's just 4.7. We are just lagging behind of Uganda. And actually we are the 12 in the ESA, East and Southern African. Female, the more affected if you look at the prevalence of 6.3. And in 2020, 68 people acquired HIV new infection, and 28% were from the young people, 10 to 24 years old. And 32 lives were lost in 2020. This according to the data from the UNAIDS. Next slide. So let's zoom in this HIV cascade in Tanzania, how we are faring up in terms of 1995. This is based on the program data. By end of 2021, we're at 88% for the estimated number of 1.7 people who are living with HIV know their status. And 97% who know their status were enrolled on care and treatment. and 95% were violently suppressed. If you look at this data, they are very impressive, but are those all the categories being involved here, or there are some people lagging behind to reach the 95%? So they may seem so good, but there are populations which are lagging behind on the 1995. Next slide. So let's look on the prevalence among the KVP. In Tanzania, the key and vulnerable populations we put together and the general population you compare. These are the estimated population in 2014. The consensus estimation process was done, and we estimated the people who injected drug were 30,000. MSM we were ranging 41 to 71, and female sex were 150,100. So, but when you look on the estimated prevalences, which was done on the BBS in 2014, the prevalence was very high along that 36, 25, and 36 according to the population, as you see in the data. But you look on the general population, we're just 4.7 as presented on the previous slide. Next slide. So these are the results of the BBS in 2019. Just we took this as that was done in Dar es Salaam. Dar es Salaam is the capital city, and it's contained the huge number of KVP or the KP population. So it seems we have done a lot of work along that. We may not be, as I said, we may not be at the optimal part, but according to this data we found in 2019, the prevalence was shown, the female sex workers, which was 15.3 from the 25%, which was shown in the last slide. And from 36% for the people who injected drug to 8.7%, and from 26% to 8.3%. So this is showing some indicators that something has been done along the way. Everyone has contributed something to making sure the KVP are being reached. So this is it's indicator of the success. We are going there. Some effort need made to lower that down, but it's showing the progress has been there in Tanzania. Next slide. So this is just a cascade in June, just to show that we are capturing some of this data. We may not capture every indicators along the KP population, but we are capturing like how many were tested in the specific period of time, how many were positive, how many were enrolled, and how many were initiated in drugs in a different category of groups, like female sex workers, MSM, PWID, and HYW in other categories. So this is an indicator that we can identify them, and still we work along finding them, and they get services, because we have a minimum package of reaching those. You cannot just reach them and test. A lot has to be done to say these services have been provided for the KVP. Next slide. So this is just to show how the epidemic been in Tanzania, and we categorize just a general epidemic. How is it categorized? For the group of key people, key and vulnerable population, are the group which they had high risk. And we have the intermediate risk, which is the section, the partners of the KP population, and we have the low risk for the people who are general population. But if you compare this with the the East and Southern African countries on the SADC, it shows now the general population is coming up. So there's something it needs to do with the how this, because the KP population doesn't live in the Iceland. They're living in the same population we are in, and they're in a high risk. So we need to look on that. Why in general population now the new infection is being raising up as we go along with all the prevention in places, interventions in place. Next slide. So let's go to the topic now. We tried to define before we deep dive on what has been done on the stigma and discrimination process. We refer the stigma as attitude or belief directed towards someone or has negative view on the belief about themselves. Views or belief about themselves. So it can be yourself or the other part. So this, the discrimination part is just the distinction or exclusion of someone or restriction of this which affect a person. May I give an example of the Tanzanian was able to lower the age of consent to 15. That can, so the 50 and under 15 years old can access services without the concept. So if you refer that, you can say that was the discrimination. Someone cannot access services because of their age, which is needed for them, and we know the risk to them. So that's the big step which was made, and that's part of the discrimination. So putting together what is stigma and discrimination this is generally denying people living with or affected by or at risk of HIV, such as KVP, to access HIV prevention, treatment, and care. That's the key area to look at. We looked at it during we are preparing these slides. So Tanzania understands this as one of the countries in 2013. We did our first national PLHIV stigma index, as other countries do. That was the first survey was done. And the survey highlighted HIV-related stigma and discrimination was at 28% in the country. It was very high. That was in 2013. Next. But some progress has been made. In 2021, Tanzania did another survey on stigma and discrimination, and thus the dropping out from the 28% to 5.5% in 2021. So is the huge milestone. Even though we know we have zero, we need to reach zero stigma, but at least something has been done on this area. So from 28% to 5.5 is a milestone we have made. Next. So what's contributed to this? We'll categorize this in different, I'll go through the government and the political commitment, then Damali will go to the next slide. So on the government part, next. What has really been done to making sure the stigma has been addressed? First of all, Tanzania recognized the importance of KP in controlling the epidemic. As we saw, we have high risk, and we have intermediate, and we have low. So Tanzania ensures successfully integrated KP services into the MOH portfolio. This was not easy, but we both know the cultural context and all that. But the engagement of KP in programming this, it was the main key to making sure this has been integrated in the MOH portfolio. Beside health services, Ministry of Health defines package for services that's including promotion, psychosocial, and legal services. So all these have been put in the minimum package to making sure the services are quite comprehensive, which are reaching the KP population. Next slide. So we decided to approach the KVP programming in Tanzania in public health approach, and we needed to put at the center client-centered and vulnerability-tailored interventions, voluntary services, respectful and friendly, non-judgmental and discriminatory care. We targeted hotspots where we can find the targeted population. Services integrated into the general health system, as I said. You cannot, we don't separate these services in a separate, no. They are just part of the services in the health system. So what we know, the population has its own peculiarity, but so we offer some verticalized services based on the specific needs of that population. Next slide. So we are able to put the stigma strategy, which ended in 2017, which addresses what to do, who to do, at what point, and the creation of stigma and discrimination guidelines, and facilitating facilitator guide for training media professionals on HIV and AIDS. And because we realize that media can stigmatize without them knowing, by how they given information to the audience, by how they address the situation. So we needed to put the facilitator guide for these media professionals. How do they inform the community without stigmatize them? Also, a facilitator guide for healthcare providers. But we made sure stigma and discrimination content being integrated in every topic in the training package. If you train HIV self-test, if you train H-test, stigma is part of and parcel of that training package. Also, we also employ DSDM to KP programming, make sure the services have been there. Access and reducing stigma and discrimination. So we needed to do an assessment, because you may say, okay, I'm doing well, but we had intermediate assessment even before the stigma index, which was done in 2021. We did an assessment of reducing stigma and discrimination in health facility in 2017, 2018, and some of the regions. And that's when we came out with strategies. Also, we had productions, we had production and airing of radio spots with the stigma reduction messages targeted. Next slide. And advocacy done to the policymakers, organized campaigns to involve high-level leaders to address stigma, that including promotion of testing and messages, as we'll see in the political part. Also, Tanzania was able to lower age, as I said, as an effort to making sure stigma and discrimination has been addressed. Next slide. So, as I said, we had differentiated service delivery. We needed to identify what service needed to the population we are targeting. So services like prevention services, care treatment, and other services like mental, legal, and rehabilitation was put in place. Then we said, okay, now who should provide that services? We identified that. We have trained healthcare providers, we have laid cadres, we have other needs, as per needs. So we may not really have all these lay cadres, but we may need lawyers. So it depends with the need. So when the need lies, we identify who should provide the service needed at the particular time. So where do we provide these services? We provide these services health facility based, also mapped and approved community services delivery points in those hotspot areas. But remember, we observe actually the ethics of the medical, but also the context of the country. When do we do that? During normal hours, but we can do weekends, weekdays, nights, all those have been days, because we know the population we're targeting may not be at a regular time as the general population. Next slide. So all those we needed to put the service delivery system and structures in place, because you can have all that where service and all that. If you don't have systems, it will be very difficult to make sure those services have been reached to the targeted population. So we needed to put the guidance, policies, and framework in places in every interventions. So we have a national KVP guidelines which directs what to do. So, and at this point we are reviewing it. We have national KVP training package and all those. So the guidelines and policies we were able to put in place. Then we needed to put the health management information system. As you saw, we can capture some we may not really capture all those, but we were able to capture informations and indicators to monitor if the services are going well, because you can do a lot of work if you don't have a system to monitor and to see the progress. There's nothing like you can measure yourself, you're progressing. So also human resources, where it was supposed to be trained in making sure the KVP friendly services are there and all those stuff, but making sure all commodity and supply, for example, commodities for HTA services, condoms, PrEP, ARV, laboratory reagents, those needed to be put in place. So we move forward. So the forecasting and quantification doesn't being done separately; it's done in the larger MOH portfolio. So if you do that for the next phase, for the general population, you do the same to the KVP. So it's the part and parcel of the system, of the government system. Also, public service delivery, both public and offering, and also the other areas. So oversight and coordination system was supposed to, we were able to put that, including national TWG. We have a KVP TWG meetings to see those, to monitor the services. So KVP TWG it exists, and actually it makes sure it includes all the stakeholders, including the beneficiaries, the KP population. They are part and parcel of the national technical working groups, and that's where for those who have started with them, we were able to put together the KVP forum. As you hear them, this forum is put together all the KP population together and have one voice. Then we have a focal person in the government which sits to this KVP forum. Also, community monitoring system, community-led monitoring and scorecard. KVP are involved in monitoring, making sure they're doing supervision in facility. Somehow you may be how that possible. It was possible. They can do the supervision together with the team and look at these services enough for them. Why other population they are not accessing? All that has been done. Next. So these are the guidelines I was referring to. All this directs how to implement the KVP services. Next. Then I just wanted to show somehow how long and how it took for us to make sure this is included in the MOH portfolio or the KP. First, it took time. MOH level evidence we needed to build evidence that we need this population to address this population. If we don't, they actually tackling the HIV fighting HIV, it will be very difficult. So we put the MOH put evidence together, generated the evidence in 2009. It coordinated all the stakeholders, do the desk review and see what is there, what is not there, is the population there we are targeting, conduct national KP size estimates. All that is one of the key area to build evidences. So, and the second step we did now is when we found out the evidence is there, the population is there, the stakeholders consultation was done. That involves everyone on board. The government, the implementing partners, non-public health expertise, all we needed to sit together and say, this is it. Remember, you don't leave the government behind, you just go with it while from the very initial phase of making sure these things are happening. So, and then, as I said, after those and making sure the consultation is done, the ministry accepted the population now we need to address. So we developed system and structures, materials and piloting, those has been done throughout. So including the KVP guidelines, develop M&E system, all those, making sure when we run. So we trained on all that. That was step 3. And step 4, we reviewed a process improvement system. So we started at least on the on the initial, like study 2 and all that was done. Review progress, improve system and tools was done at the first step. So we were able to start in a small scale. We didn't start at the large scale. So we were able to start at the small scale to see how are we faring now, how the context, how the country accept the feasibility of it. So all that. Then we reviewed, and now we roll up the countrywide. So the KVP services are there in countrywide. At this point, ongoing services and the improvement is ongoing. As I said, we are not there yet. So we are reviewing KVP guidelines to include the new interventions, all that has been done. So this we were made possible from the very start. Everyone was on board. Next. So all that was possible, as I said, because of the meaningful engagement of the KP themselves without leaving anyone behind. So KVP has been involved in design. So we designed together, implementation, monitoring and evaluation. But all of us, we made sure the context was observed. Next slide. So that was the government part. Now let's see what is the parliament done. What is the political will? Doing things without the political will is a bit of hectic. A lot of questions and rejections. So presence of HIV and AIDS Parliamental Committee is there and is responsible for drafting new legislation to address the HIV and review, amending all those. So HAPC amendment or the amendment of the prevention and AIDS control was done by this by the support of this committee. So it's very important of the involvement and making sure these services are there. So they recognize the presence of the KVP. First of all, we needed to show the parliament that, okay, this is the problem is there. Can we solve? Can we sort out? How do we sort out? Let's all move together. So we moved together with this committee. Next slide. Another political will was alliance of the mayors and municipal leaders on HIV or AMICAL. Some of us, we know AMICAL is in AMICAL is in our regions. It's not only in Tanzania, but this AMICAL was very active. The members were, we know members, for those who don't have this, but there are some, most of the country have this. So it's made by selected leaders, honorable mayors and councils. Remember, these have peoples down there. So it was very important for them to be active. So there was enable members council to identify and prioritize intervention for the vulnerable group. But each member council is supported to develop and implement a community-based HIV strategy, focuses on the vulnerable group in their area. So they identify needs from their area. So they were able to train key stakeholders, including law enforcement and AIDS among. So it was easy because if they're trained by the mayors, the law enforcement is quite easier compared to if Dr. Kagashe goes to train the law enforcement without them, sometimes becoming very difficult. But involving them, it was important, making sure they take lead of this. So they were able to create environment and other good stuff. So AMICA was very helpful during this period of making sure KVP programming is success in Tanzania. Next slide. Also, we have another association called TAPAC. This is it's just a coalition which was made by honorable members. We can differentiate this, that the committee is there according to the law, but this just was made, an effort made by some members of the parliament. So they're addressing HIV and AIDS at the workplaces and within the constituents. So the main agenda was stigma and discrimination for PLHIV, key and vulnerable population. But always we remember, observe context and community around that. Next slide. So that's one of the political will, we call it. That is the Prime Minister showing that you can test HIV without any problems. HIV doesn't look you are a president or you're what. Everyone needs to test, everyone needs to search for services. So he was leading men to test. So we started this and it was a very success, showing the Prime Minister showing himself that I'm testing now, where are you? So it's a political will which makes a community listen. Next slide. As I said, so this is the campaign in 2018. And if you look at this, we have ministers who were there. So the presence of this makes the HIV fight being more, it makes sense to the communities that, okay, this is serious. If the ministers and other political figures can sit and address this, something we should look at. Next slide. And that is the Minister for Health, Umi Mwalimu. So she's able to launch she was launching a campaign in school adolescent girls just to address HIV/AIDS, sexual reproductive stigma and discriminations. She was using a celebrity. So if the Minister for Health stands there to address this publicly and all the stakeholders around, that was so helpful during the addressing this stigma and discrimination. Next slide. And the impact of this, if you look at this, this is Neema. She's HY living with HIV, and she was able, because she was doing this with the Minister for Health, she was able to stand and address adherence, disclosure, and promote the use of friendly services. So that's the beauty of including everyone on board, taking everyone on board, just to making sure we are moving forward. I think next. So let's hear from Damali as how does the implementing partner addressing this? Thank you so much. Damali,
thank you, Margaret, for that wonderful presentation, very comprehensive, telling us and giving us the ingredients from the government side. Before we listen to the other side of the coin, the implementing partners, I understand that Gina from the Bill and Melinda Gates Foundation is in the room. Gina, kindly introduce yourself. We don't want to lose a very important partner.
Good morning. It's nice to be here and great to listen to this. Thanks.
Welcome. So, Damali, you're next, and then followed by Mhando, and then we can go into the session of discussions. Karibu.
Asante, good afternoon all. As I've been introduced, I'm going directly to how we are doing for stigma and discrimination reduction for KVP service provision on HIV/AIDS. Okay, the slide, please. What should it present?
The slides are in the same slide.
Okay, thank you. So on behalf of IP in Tanzania, I'm going to present about HIV KVP program implementation in Tanzania. And these are the pictures of the first one is the Mati Clinic for Tunduma, which is the border between Tanzania and Zambia. And another was a sensitization meeting to law enforcement, which was done in Songwe. And another picture is for Dreams Girls from there in Mbarali district. Next slide, please. As what have been also presented by Dr. Margaret about the service package for KVP have been categorized in 3 packages, which is behavioral change, communication, which promotes HIV education, condom use, uptake of HIV testing and counseling, Also, it involves community peer education, whereby all the KVP peer educators recruited are involved in this behavioral change communication after being trained. Also, they are managed to mobilize their fellow KVP to demand for prevention services, those available at the community and also at a facility level. Also for biomedical services provision like HTS, which are provided at clinical setting and the community. Also other services are VMMC, PrEP, KP MAT, which is part of biomedical and prevention services to key and vulnerable population, especially people who use drugs and people who inject drugs. For structural package, these are the services provided to create the better environment for KVP to reach or access services or reduce risk which might be caused them to access to get HIV. And some of the program done under this structure are stigma and discrimination reduction programs, whereby this is done to KVP themselves, whereby they are trained on the importance of their health, on the importance of prevention services, especially to prevent themselves from HIV, from hepatitis, and the other bloodborne infection diseases that might be caused by risky practice like sexual and maybe injection practices. And also there are some economic impact mitigation, which are eager support for different groups of KVP. Some of the KVP who are in need or who have been assessed to get eager activities are trained, supervised, and mentored, and there they are given the support to initiate their income generative activities so that it will support them economically and enable them to earn their living or to support their family. As we know, some of the KVP have their children, have family. So, and some, when they are engaged in economic activities, they can improve and reduce the risks of HIV infections. Also, we give them a chance to get skills development and vocational trainings. Some have been getting maybe formal education, but they don't have skills on how to use that education to create some activity that will make them to earn some money or to earn some income so that they can support themselves and their family. And some are sending to vocational training after their needs are assessed, like mechanical, or they wanted to get issue like sewing or cooking or batik made, cloth making or welding. So it depends with the needs of this KP. So all these are the kind of services which are support KVP in service provision so that at least it might increase support in their HIV prevention activities. Next slide, please. As the IP in Tanzania, we are working in multi-sectoral collaboration. We are not working alone. We are working with the government and the other stakeholders. So we supported the government in HIV program implementation to the health facilities and at community level. So in working with the government, IP are providing, like in implementing HIV program, there are sometimes we send the contract or memorandum of understanding on how we can work in order to support these HIV activities. Also, there are some councils get direct fund from IPs, and also councils, last offices, referral hospitals, or some of the part of the memorandum of understanding and the support fund they get direct from IP. Also, IPs are providing biomedical equipment to support the improvement of service delivery at facility, HIV service delivery, or improve laboratory activities like diagnosis and improve of quality testing on different issues that services which are very important on HIV issues. Or another activity that support the government which IP are doing in Tanzania, IP supported the government in renovate some building for HIV service delivery like CTC, and sometimes it depends with the needs of the council or the district that will support them in service provision to KVP. And also the IP are providing some vehicles. So these vehicles or motorcycles are used to enable making follow-up for HIV program activities, and also sometimes they are used to reach in hard areas where KP are, or in the islands, or in the shore or hidden hotspots, so that it will be easier for them to access the services through outreach or through other areas which are available for service provision. Also, IP conduct HIV program support supervision with the government officials. Ministry of Health staff are invited in different regions to go together with the regional and the council team so that they can go through all facilities, the CSOs, to see the package of service, quality of service, and where the gaps should be improved. So we are working together with the government and the other stakeholders so that to improve service delivery and to accommodate the need of KVP. As we know, some of the staff who have to be trained, or some staff who trained but are transferred to other areas, so they need regular monitoring and supportive supervision so that it could not create the gap of maybe stigma that might hinder the access of HIV services among KVP. Also, there is technical support providing to the facility and the CSOs who are working with the KVP. And now in Tanzania, we have KVP Forum is part of the technical assistance used in all over the countries by IPs. We are going together in the facilities, CSOs, and provide TA for those CSOs who are working with the KVP, and also at the facility level where KVP are referred for services, and some are getting their treatment services. So during that support, supervision or technical assistance, we identify the gaps and see where there should be an improvement, or if there is a gap of training, we see how to overcome that so that KVP could get or access the services without feeling they are stigmatized or denied services due to their status. Also, the IP will strengthen and support KVP peer education program. All the peer educators are coming from KVP community. As we know, peer educators from the KVP community, when we engage them directly, it will be easier to reach even those who are hidden. They know where they are, what they want, and how it should be provided so that it could be the friendly way of service provision to them. So they are engaged, they are recruited, they are trained, mentored, and coached. Even they are sending to some different occasions to learn, to get the experience on how they can improve service delivery in their catchment area. So that's how it is done. Thank you. Can for another slide, please. So when we go on how stigma and discrimination is done for KVP, is addressed as IP. For at the government level, IP, we conduct sensitization training, like to law enforcement agencies. As we know, in reality, sex work, drug use is still a criminal. So if we are not sensitized this law enforcement, it might hinder the access of health services. As you know, sometimes it happens during the patrol, some KVP are arrested and taken to police. Maybe some are charged, or they are fined, or they are putting in a cell also without any support. So if we are not this law enforcement being sensitized, it might not be easier for KVP to access. They will hide and they will do risky practice, like maybe injection, unsafe injection, or unsafe sex, because they will not be able to reach for condom or any HTS services. So it will be easier if they will be trained to understand the needs of the KVP and why KVP should be saved on HIV prevention services. So this is done on regular basis according to the need and the challenge of the region in which it seems the need to train, and it is done. And some of the IP are going to the police institutions and provide training on how to work with this KVP and support them, even if they've been taken in or they are in custodian, they have a right to get a treatment like maybe TB treatment, ARV or methadone, and some of law enforcement are escorting this KVP or call their relatives so that they can support these arrested people to get their treatment. Also, member of the Parliament has been, it has been said by Dr. Margaret, also they are part of Parliament, remember they are part of officers who should be sensitized to understand, even if they are making laws or policies, should be friendly and not increase more stigma or any might not cause any violence. So they are sensitized on daily basis. They are taken in different areas to learn, to understand why this is important and how, if we support or we save KVP, will help in reducing HIV infection in the general population and the country at large. Also, local government officials like from regional, maybe commissioner's office or from street level, as we know, most of the street leaders, also they are part of the community. In some of the areas you might find is some street leaders, they call for the police. Maybe there are these sex workers who are doing here, they disturb us, or there are people who use the drugs, you should come and arrest them. So also they have to be trained, they have to be sensitized, they have to be tell the reality of HIV infection, how it goes. They have to understand that this HIV will not only end it to KVP, also it will come back to us. So as IP, we do this in different areas according to the needs of the area in order to create the enabling environment for service provision to this KVP, and the KVP, they will feel free to access the services. And even if some KVP have been arrested, they feel because they've been empowered, they can say, maybe I'm using this kind of medication, kindly, I need to contact someone or a peer educator or facility worker so that they could be easy to access their services. Also, healthcare workers who are the service providers, they have to be there. We build capacity and train them on how to provide friendly services. As you know, if to change the healthcare workers' attitude, it takes time. So they are trained on regular basis on different curriculums so that they could understand this KVP. They have the right also to get non-stigmatized health or HIV services. They are trained, some of the facilities are providing services during the evening hours so that to accommodate the time where this KVP are available. Also, they are trained on gender and sexual diversity. They have to understand we differ, we are not the same according to our sexual maybe orientation, the gender. So they have to provide these services according to the need of the gender or the sexual of a person which is belong. So that's how they are trained. Even staff from IP, we are trained on that. Wherever we go for technical assistance or we go for supervision or mentorship, we have to understand this. The important to understand the kind of the people we are taking, they are part of the services. Also, lives training also is conducted to this staff so that to understand and not support KVP. Also, peer education, it has done. Peer educators are recruited from peers, they have said, from the community, and also for the community are sensitized on the family. Some of the KVP have been gone away from their family. So there is family integration session and the support grant, for example, for recovery for people who use the drugs and the other treatment adherence for some KVP. When they'll consent to communicate or to contact the family, the program is doing that so that they can be reunited with their family. Next slide, please. For deployed intervention, stigma and discrimination, as you understand that you have MATI program in Tanzania. In our MATI services program in Tanzania, it is one-stop clinic whereby all the services are needed by the MATI grant is provided under the same roof. So like HTS services, lab services, and all the services, TB diagnosis is done at one-stop shop. So that's how it is done in Tanzania. Also, peer educators services, they are recruited people who use the drugs from the community, and those are the part of service providers, make follow-up, identify follow-up for defaulters, and the other for family therapy. Also, training to sensitization meeting for law enforcement has been explained before. Also, legal support services is provided for clients who maybe encounter a legal issue. So they are trained on crisis response, how to do, and they've created their crisis team, whereby whenever there is an illegal issue, these trained peer educators are going directly to find a solution to this crisis. Maybe it is an overdose, or policy arrest, or family challenge. So they are part of the team to support this the crisis, or if there is any legal issue needed to be followed up. Also, integrated sensitization program for family members, as I've said before, for reunion and recovery or treatment adherence. Also, training on healthcare workers on a friend safety provision to people who use the drugs. I've said so that it will be easier for them to reduce the stigma, to understand the service package, and how to provide in a quality way to avoid stigmatized environment. Next slide, please. Also, IP has integrated in KVP population to improve KVP service delivery. As we have said, we are working with the KVP forum. So there are about more than 30 CSOs who are KVP led, are working with the IP in different regions to provide or to make follow-up on service provision for KVP. So they are organized to be provided in training. Also, they are trained on friend service and what should they make follow-up during the TA or supervision, including PrEP provision. Also, they, in support from IP, they are working with the RHMT. For example, there is this NGO called the Southern Highland Youth Initiative. So we have a lot of them CSO KVP led. We visit a facility together, talk to KVP, talk to the facility, know their gaps, challenges on how we can overcome this so that there could be a friendly service provision to this KVP. Also, they are part of their identifying proper peer educators for KVP that were engaged in identification, escortage, and linkage, even to make support and support for HIV services. So through the engagement, it has been possible to identify the stigma and discrimination issues here and address according so that we can accommodate service provision to KVP. Next slide, please. Stakeholders also at the IP, we are working with the different stakeholders. We have our engagement model in KVP program implementation. As I've explained before, we engagement of the KVP, like KVP forum and the other CSO, KVP led, IP, and the government, you are working together. Also, legal issues, you might find most of the CSO staff are trained on how, on like legal issues, how to address when there is a challenge, where to go, whom to contact, how to do it, and share the number for legal support from their fellow peers or CSO who are working in a certain region or district. Also for medication, we get the support. Like, for example, when some of the KVP are arrested at the police station, they can inform the police officers, maybe I'm using certain medication to a certain facility, could you maybe contact all my fellow or my peer educator so that I can be easy to access either to get my ART or to be escorted for methadone services. Next slide, please. And also for law enforcement, the part and parcel of the program, we are doing sensitization on regular basis that led to reduce the stigma and discrimination reduction for KVP service delivery. And they are very positive responding to this sensitization meeting. At the end of the training or that sensitization meeting, they are coming part of the program and they are coming part of this HIV prevention services. And some you might find that they call whenever maybe some have been arrested, they might call a certain COC, maybe come there as your people, you have to come and support or provide any legal assistance which might be lead. So that is how we are working. Also the family, also they are part of the party, and this also a concern about the consent of the KVP. If we really need to be reunited with the family or to need to, there is high stigma in the family, we find a family through peer educators, through staff, and go together, we discuss and see how they can support these people, maybe in their treatment, adherence, or to recover from the issue they are facing. Another slide. Okay, thank you very much for listening.
Thank you, Damali, for that passionate presentation, sharing the experiences from an implementing perspective. Let's now hear from Mhando with the KVP Forum. Mhando, karibu.
Asante. Hello, everyone. Good afternoon. My name is Mhando, aka Michael Entail. Okay, this is the voice of the KVP, representing KVP from Tanzania. And as I work in prevention and sexual orientation, gender identity and expression department. So I'm going to present stigma and discrimination, and this is all the way from the mouth of the K population or K and Bantu population in Tanzania. So I'm going to go direct to the current situation right now. So the establishment of KVP Forum at the national level, as we all that the government and PEPFAR have succeeded to establish this forum using the KVP led organization from all regions, like almost like 26 regions in Tanzania. So it is at the national level right now. So the KVP Forum is there to make sure that stigma and discrimination issues are being handled the way are being handled in a good way. Also, the government is working closely with us to overcome and also reduce stigma and discrimination by providing training to healthcare workers, engagement of KVP in planning. So since then, since the formation of the KVP Forum in 2018 under the Ministry of Health, it has been nice because the government has been working closely with us as KVP Forum to tackle issues concerning HIV services and key population programming in the country. Also, the government is working closely with us to overcome and reduce stigma and discrimination by working closely together with us, as we all know that there's nothing for us without us. If the services are there for KVPs and we are there, they have to engage us. So in this collaboration, we have managed to reduce stigma and discrimination. As we KVP Forum, we have been observing observing these situations, as now we are being involved in day-to-day planning, also in training and workshops. So they need our contribution, and we need to hear the voices of the government and other stakeholders. So as I said, working together closely with the government, the Ministry of Health, for us that at that level, I can say that this is called a good collaboration that has reduced stigma and discrimination towards KVP groups. Being involved in different technical working groups. So that's why. So also I would like to talk about being involved or engaged. It is just a kind of repetition, but being engaged in HSSP 5. For us, it has been a good thing for us because we have managed to make sure that our things are right there, so that we can move forward with anything which concerning the KVPs, as long as we want to make sure that the comprehensive packages for KVP are being there for us to access those health services. Next slide, please. Yeah, so still talking about reducing stigma and discrimination for KVPs by engaging us, but the government itself has been taking these initiatives to sensitize actors in health sectors, police departments, and also even president's office. And they make sure that these people in these sectors, they know how friendly services for KVPs looks like, because sometimes you might say, this is we need friendly services, but how this person would understand that, how that friendly services looks like. So the government has been there, thanks to the government of Tanzania, that through NSAP and TACAIDS, they are trying to sensitize actors in different sectors to make sure that these interventions are being implemented smoothly. Also, IPs and development partners, for sure, are the frontliners. To make sure that the KVP, forum and its member in different regions are getting support. We have been getting support from different partners, and this shows that implementing partners have been supporting both KVP and its members to access funding, which will bring impact to KVP welfare, enabling implementation of programs and enable effective outreaches. Of course, thanks to UN agencies, PEPFAR, without forgetting, we have HJF here, MDH. We have been working with them closely to make sure that these things are moving on. So also, different KPs, of course, outlines different KPs having these challenges. Sometimes you might see the government had put valuable deliberate effort to ensure effective combination prevention services by ensuring adequate availability, distribution, and accessibility to condom and PrEP to KVP. We have been sometimes we had those days we had challenged that the services is available but it's not accessible, and sometimes if it is accessible, it's not affordable. So those are kind of, but the government was since then have put some efforts to make sure that these combination prevention services are available and accessible and even affordable. We have challenges nowadays of STIs to KVPs that they have to make sure that they afford the treatment. And also, we had issues of being rejected when it comes to that KVP organization wants to register an organization for service providing, especially when you target the KVPs. So the government has sensitized registration officers at registrar's office on KVP is to make sure, to ensure they understand the importance of KVP, HIV programming, and contribution of KVP-led organization toward achieving. So we have been participating on this, and we have been witnesses this with our own eyes to that the government has conducted different meetings to make sure that the registrar offices understands KVP HIV programming, so that even when we go and to register our organization, we won't face this challenge. When it comes to support of KVP Forum to make sure that we are in the COP, I would like to tell you that without PEPFAR, KVP Forum would look like an orphan child. But now KVP Forum is no longer an orphan because it's a golden child. We have both. We have the government, we have the PEPFAR, we have both parents with us. So it's easier for us to address issues and to collaborate and accommodate issues as long as we go with, we are not out of the context of the country. Thank you. Another slide, please. So I might say that before presenting how KVP Forum works or operates, I would like to say, I remember Dr. Margaret had been saying always that everybody needs each and everyone as we fight HIV and AIDS. We need each other. So if the KVP Forum is there at the center, we need the government, and the government needs us. We need UNAIDS, we need community, we need all of it. So as you can see, this colorful and beautiful thing here is representing us, how we collaborate with healthcare workers, peer educators. Of course, we own peer educators. Whoever IP is using peer educators, he should know, he, she, or should know that peer educators belongs to KVP Forum. So this is how we work together. We give feedback, and how do we work on this? This is through technical working groups and through maybe funding and technical support, and even bring issues from the grassroots, from the communities, and bring issues from the community healthcare workers, and even share knowledge and experiences around the KVP groups in Tanzania, because we all know that we have challenges. So it's like this, like as Dr. Margaret said, we need each other. Everybody needs, you need me as a KVP, and I will need you to support me and being my ally, because there is no something for us without us. So this is a kind of a thing you can see how we work with us. I think next slide, please. So we have learned a lot from there. We have learned. You can see from us, we see that the KVP groups it's now has to collaborate with the government and development partners. Those days it was like we are the antagonists, that like we cannot sit at the same seat. So it's time now for us as beneficiaries to collaborate with the government of Tanzania and development partners to make sure that this, we are moving forward. Because if we don't collaborate, we cannot even work together as it is needed. Like, we have a lot of people to serve, so we have to make sure that we are together. So also, we have learned that KP communities ought to be sensitized. Us ourselves, we need to be sensitized and get informed about the availability and access of health services in facilities for us, because the services might be there, but who is getting information that this is available there? For example, now in Tanzania we are having PrEP programming, but sometimes myself, I'm receiving calls from a certain person, like, you are giving people PrEP, but I'm not giving people PrEP. PrEP is available somewhere in the facility or somewhere. So there's need of having more materials to create demand and inform us about what is available in a certain facility. Also, stigma index is highly needed to articulate roadmap to end both internal and external HIV-related stigma. We have issues on political declaration that it is very important that having a good political will, it makes our intervention go smoothly, as we know when it comes to politics, it might change people's life perception and traditional beliefs. There's a power in political issues when it comes to KVP related matters. So also joint intervention between KVP Forum and public-private stakeholders is very important to make sure that stigma and discrimination are being controlled, and to make sure we reduce it so that we can have access, as we beneficiaries, we can have access to HIV and STI services. For example, KVP-led COCs and groups, they operate peaceful and implement their programs with the support from the public and private stakeholders, but still we have to put more effort to make sure that we have more joint intervention from the scratch, like when it comes to planning, when it comes to implementing a kind of a sustained project, that we are being involved to provide the technical support, because UIPs or the government or whoever is serving us and has to receive something from the word of mouth from us. Yeah, next slide, please.
Okay.
Thank you.
Koech, can I wonder?
Yes, Margaret. Karibu.
So in winding up, the lesson learned from the KVP voice we have heard, just what we learned, the meaningful engagement of the KP is the key. Advocacy to the policymaker is an advantage in fighting stigma. Involvement of all the stakeholders on table, from the planning level, designing, implementation as per country context is vital, making sure the stigma and discrimination has been addressed. Strengthening reporting system to capture more data to make sure we are monitoring these services is also, we are not there yet, but we are continuing to improve that. As next, my last slide is, as Michael said, I always say everybody needs each and everyone as we fight HIV/AIDS. That Kagashe is me. Thank you, Mwenyekiti. Over to you. Now we are done with the presentation.
Thank you so very much, Margaret, Damaris, and Mhando, for the wonderful presentation. If we were in a room, we should have done a round of applause. So for those who are digitally enabled like me, a thumbs up or a clap for the team for a job well done. So colleagues and friends, you heard from Team Tanzania, the journey on working with KVP, from the political will to the implementing partners and to the KVP themselves. It's now time for us to have a discussion, and to lead us in that session is my able co-chair, Pendo. So Pendo, over to you.
Asante sana, Koech. Thank you a lot. Thank you, everyone, and thank you to our colleagues who presented. They did a very good job. Now moving forward, we are going to to have a little discussion, or a very detailed discussion on what has been presented from Tanzania team. And we'll be guided by 3 questions. What really surprised or impressed you or concerned you about Tanzania's approach? And then also other key question will be how can cross-country learning be applied practically based on what Tanzania has been doing? So how can other countries apply this practically? And then the third one will be which conversation can now take place across or within the country? Now, as we know that we are more than 4 countries together here in this webinar, what conversation are you going to take home, or what this presentation will steer conversation, what kind of conversation in your home country? So I welcome questions, And I see immediately one hand up. Sorry, I cannot pronounce your name correct, but it's Lawrence, I think. Karibu, welcome.
Yeah, obrigado. Posso? Ok. Bom, meu nome é Lourenço Chumbane, sou de Moçambique. Primeiro, parabenizar pelas apresentações e dizer o seguinte, tem os seguintes comentários. Primeiro, fazer um comentário sobre as ações que são levadas a cabo, em particular a primeira apresentação, que falou mais assunto do estigma e discriminação para a população chave vulnerável. E eu acho que não ouvi muito sobre a questão, há várias ações viradas para os provedores e outros, mas não ouvi muito sobre as ações sobre do autoestigma, né? Que muitos pacientes, na verdade, a experiência de Moçambique, muitos pacientes têm problema de autoestigma. Em vez de serem estigmatizados por outros ou pelos provedores de serviços de unidades sanitárias, eles também têm autoestigma por não aceitar o seu estado e outros fatores. A outra coisa nova para nós, como Moçambique, como sociedade civil moçambicana, são ações estruturais, porque vi ali ações de comportamentais, ações biomédicas e ações estruturais. Nas ações estruturais eu vi que há ações para o desenvolvimento de autorrenda, não é? Aquilo que é o desenvolvimento de atividades para os pacientes ganharem a renda. E é uma experiência nova para nós e gostaria de ouvir mais sobre isto, para podermos partilhar com as outras organizações da sociedade civil moçambicana. Muito obrigado.
Oh, thank you a lot, Lawrence. Thank you for your question. I don't see any other hand. So I welcome Dr. Margaret to respond to that. Okay. So his question, if I may recall, he's asking what approach are there in place to address self-stigma? So as from the presentation, most of the approach which you had presented targets external stigma. So what is there in place as a country which is doing to address self-stigma? And then the part two, or different question is, he's asking more information on the income generating activities for the KVP in place. If you could give a little bit of details on that. Karibu.
Thank you, Mwenyekiti, Co-Chair. Just to reiterate what I said from the very beginning. As they said, without them, there is nothing for them. So the self-stigma starts with them, making sure they recognize themselves, the importance of for being part and parcel of every intervention we make. So we first deal with the KVs themselves by making sure we have peers who knows themselves, and they help us just to reach others, because if they don't know themselves and they don't know what they do, first of all, they accept themselves. That's the first number one. So that's where we deal with the self-stigma. So we recognize this is who we are. Then the next step is just making sure we go and make sure the other KVP recognize themselves through us. So that is the first part of addressing the self-stigma for themselves. Yes, we recognize that self-stigma was huge, because if you don't want to get services because you're afraid you'll be seen, you'll be doing what, that was self-stigma. So addressing that is making sure they recognize themselves, recognize the environment around them, and making sure they know themselves and being confident of what they believe and do at that point. So that is been doing in the community. If I can answer on the issue of, as Damali said, on the issue of economic empowerment, if I heard it correctly, we have different levels. We have guidance on how we should give those economic empowerment. Like, for example, it was given example on the people who inject drugs. Is a bit tricky to making sure that they recover completely. Then after recovery, if you don't create the environment for the economic empowerment, definitely they will engage themselves in the high risk. I remember now we were able to create economic empowerment for female sex workers through SSLN. We have the document which will be used for reviewing our KVP guideline. And that document, it gave us the information how those economic empowerment should be. How do you define by economic, because the definition of economic empowerment, it may not be look the same as their definition, because we may think it's just giving them money and do the business and just do that. No, we didn't find the way that way when we did the situation analysis and deep dive on what do they really want? What does it mean when they say economic impact? What should we do? Which services should be provided to them and they can be financially stable? So we are looking in a different angle, not only by giving them money or doing what, but we make sure we put them and understand the importance of being for being safe. Then for you to be safe, what do you think this is okay? This will enable you to be financially stable. So that's document, I think when it's done signed, we'll share with the other countries and see how the female sex workers, how the period. So we are doing the situation analysis to look at which under Global Fund, we have situation analysis on the people who injected drug, MSM. So we'll be looking on those categories. How do they define economic empowerment? What should be done to them so that can be the financial stability to them? Over to you, Mwenyekiti.
Thank you a lot, Dr. Margaret. Thank you for a very elaborative response to the questions. Now, I welcome more questions. Looking for any hands, if there are any hands up. Okay, while we're waiting for people to marinate on that, you have the remote hands later. But we have a couple questions in the chat box. And the first one was more of a statistic questions on the presentation, on the slide you presented on people who inject drug. And I think it has, one of us has had responded to that question. Perhaps you could add a thing or two. And the question was about the difference in the prevalence you presented among the people who inject drug, the 10% and 8%. I think that one is responded already. And the second question I see was, yeah, these are many questions. Yeah, it said, how do you deal, or as a country, how do you deal with change in leadership or different, say, transfer or different leaders of the programs? How do you deal as a country as it may affect the program? So I see there's a response from the implementing partner, but perhaps we could also invite you, Dr. Margaret, to speak for the government of Tanzania. What do you do? What is there in place? That will be the guiding, let's say, maybe guiding document in case there is a change of leadership or governance, just so the program is not affected. And then the second question is, how do you deal with the KVP arrests? And also that one is responded to. You can also add a thing or two, Dr. Margaret, karibu. And the third one is negative media publicity. How does it affect the good work, and how do you deal with it? So if you could add a thing or two on top there of what has already been responded. Karibu, Dr. Margaret, tell us more on that.
Okay, probably I start with how do I deal with the change of leadership, as actually Damali explained very well in the chat box. But at the government side, as I said, we have this parliamentary committee, and any leader who is being selected, they have the time, the schedule for this committee to take place. So one of the key issues in our programming, we have every year twice making sure we are reaching these political leaders with advocates, training, and some new interventions. So we have it in the plan. But also they have plans. The committee has their timetable and schedules to meet with the specific areas. Like for the HIV and AIDS Parliamental Committee, they had their timetable to see, because they are new. All of them, they are new, including the chair of that committee. So they need to hear from us what has been done previously, so that we have those both together. If they don't call us, we just go, because we have it in the plan already, that orientation of leaders and new leaders is there. If we don't use for the entire, actually we use it for advocacy and everything. So it's already planned throughout. It may not be frequently, but at least thrice a year we do it, making sure we are reaching the parliament in those. For the ministers who come new probably to the organization like Minister of Health, the organization memory must be there. So we provide that. We prepare the report on the progress on each and everything which has been done. So it's the work for the leaders now to go and brief that leader who has been selected now, and then making sure that we know if there is something new we need is how he or her attention, just been written and then present and ask for the management to go through that. On the issue of the KVP being arrested, what do we do? One thing I want to clear that being KVP doesn't remove your transgression. So if you have your mistakes, you have stolen things, you are doing what, doesn't remove for being KVP. But what when we corroborate with the IPs in the country, with the KVP themselves, make sure that these law enforcers, they get, we orient them the importance of that, because that's the human right of making sure if he uses ART, let them use, despite of is behind the bars, but using the ART, getting the services is the right of any person, despite who he is. So we are doing that. We orient those in every region, because we have IPs in every region collaborating with the government. So that is being addressed. I think that were the questions. So
I just want to add on that, Dr. Margaret.
Yes.
Yeah, this is Michael from KVP Forum. I would like to say, to add on that, thank you, Dr. Margaret has been elaborating very nice. But thank you to UNAIDS. Thank you to Grace Mali. I just mentioned you that there's been an effort made by UNAIDS that they have emergency response thing when it comes to KVP arrests. Then UNAIDS is there to support and see how they are going to handle the issue, because you might sometimes there's a lot of violation of KVP intervention programming sometimes because of some miscommunication. But as Dr. Margaret said, they've been doing a lot of efforts, but UNAIDS is behind us to make sure that people are being trained. Of course, the KVP themselves are being sensitized on legal issue and everything to make sure that they have a chance to explain what they're really doing in the community when it comes to outreach work. Thank you.
Chair, if I may.
Yes, Karibu. Welcome.
Thank you. I mean, this is a very interesting question that has been raised, the issue around how do we sustain the progress that we have made if there is transition. The answer to that is, if you listen to the presentation, that this is really a collaborative effort, that success does not lie on the shoulders of one entity. It's both government, working with the local authorities, working with communities, working with implementing partners, working with development partners. That really ensures that there is sustainability. So that if one part, there is a change, the other parts kick in and that transition becomes very smooth so that the knowledge remains with the community. I think one of the success factors really of the KVP Forum in our experience in Tanzania is that this has become a platform that becomes the glue between the KVP themselves, the development partners and government in providing homegrown solutions to problems and being an early warning mechanism to tell us that there's something that is going on here, can we all intervene? I think last year and the year before, we did a very elaborate exercise, which we called the stakeholder consultation, which started at the district level, bringing the leaders in the community, bringing the implementers to have a conversation around these difficult issues. And that has really borne a lot of fruit in the sense that we can now have that conversation in the community. And people will challenge anybody else who is coming with a different conversation. And for me, that is really one of the ingredients of the success of this programming. If we put it at the community level, we have the conversation all across the board. It will be very difficult to wash away, even if there is a change in leadership. Thank you.
Thank you, Koech. Thank you, Michael, and thank you, Dr. Margaret, for a very, very detailed response to the questions that were asked. So if I may summarize on the response that we just received, that the government already has it in place in their programs to sensitize all new leadership or in terms of any transfer of one of the key players. So they already have it in place in their program to make sure they keep on sensitizing. And about the KVP arrest is that it's a teamwork which involves all key stakeholders. And one of the important messages is that even the KVP themselves are already sensitized on the legal issues, so they know when to raise a flag and where to get help. And as well as the police and the legal department is well sensitized also on how to deal with the KVP. So thank you all who responded. So I'm looking for more, I'm looking for hands up if anyone else has a question. Koech, I see your hand is up. Do you want to say something?
Thank you, Chair. I mean, the chat box has been extremely busy, reactions and questions. And one of the questions that have really come up, and I think, which is a critical question for all of us, is how do we share this learning? And I think we should take a moment, maybe 5 minutes, to really come up with suggestions on how do we broaden this collaboration? How do we expand the knowledge base? Because there's a lot of wonderful things that are happening at the community level that others could learn from. Elga from the Global Fund has suggested that maybe we should consider a website. I think that's a brilliant idea. But what other innovations can we have? There's been a suggestion to have a YouTube channel. Great, we're in the age of social media. There are a lot of TikTokers. I'm very sure that even in this congregation today, they are experts in this. So please, colleagues, share those suggestions. How can we make this success across the board, learn from one another, from Mozambique to Abuja, from Geneva to Johannesburg? Thank you.
Thank you, Koech, for highlighting that. So I'm in full support. Perhaps we could hear from everyone if there's any idea, any further ideas on how we can make it best. How can we share the information that we're learning and the best practices across the board? How can we make it available and continue, let me say, sustainable for all countries to learn from? So I don't see any further hands up. Perhaps Koech, my co-chair, if you advise me, perhaps I should return the mic to Lulama.
I
think we have a next slide for the.
We look at the next slide.
Prior to that,
Chair, is a message that your 3 questions were not responded to. People were not surprised by what we are doing in Tanzania. We're really eager to hear from all of you, and maybe I could be a little bit provocative in this reaction. I want to hear from Nigeria. What's your take? What's it different that we can learn from you if you're not surprised with what we are doing? So Madonna, if you're there often, please say something.
I think we'll leave the country, the people representing NACA to say something. Madonna and I are on the SSLN side. We might not be in the best position to say something about how it's done in Nigeria.
Okay, so.
But I'm sure there are people from the government here or implementing partners.
Okay, so Nigeria has you were interested, Uganda? You're our neighbors here, so it may not have been surprising, but there are things we could learn from you. Yamuka. We're all quiet, huh? Hello?
Yes.
We want to share and listen to one another, please.
Yes, thank you.
Yes, Peter.
Dr. Mdiope. This is Peter from the Ministry of Health. I thought Daniel Vyamukama was going to respond. The country already has a stigma index policy that actually currently the Uganda AIDS Commission is rolling out in the field. And probably the key population response is just as similar as the presentation you've made. Luckily enough, we have the regional program of the East African community, which brings harmony among, or harmonization among the different countries in EAC. And quite a number of those issues have been discussed. I think Helga Mshoki from Kenya can agree with me on this. And many things have been harmonized. What is always the question on table, probably from the governments, is what is the contribution of the response in the KVP in regard to the contribution of prevention of the new infections vis-a-vis the investment compared to the numbers and to the general population. But to the question you asked of sharing the information, we have quite a number of forums, and I agree with what colleagues have suggested. Helga, I salute you. But also I propose that the platforms like the East African Community Technical Working Groups and steering committees can really be used as a platform to, or the knowledge management portal of the EAC can be used to as a platform to share the information. But also as we can come up with some kind of social media or WhatsApp group that can keep on communicating, since we have so many challenges that we need to address. I don't know whether there is a program at the CDC of African Union that can bring the whole of Africa together to discuss these issues, but I think we can really also look at the regional, the RECs, the regional economic countries. Over to you, Chair.
Thank you so very much, Peter. Brilliant suggestions, the need to engage the RECs, broadening the conversation, even with the now fully fledged African CDC. I was hoping you would say that also using Swahili now that it has been adopted by the African Union as one of the working languages, but that's something we can look at. You talk about stigma index, and I think many of the countries in the region are really in the process of either finalizing the stigma index or beginning. And for those that are COP countries, it has now become a requirement that every 3 years we should be doing this. So I think we're finding areas of convergence and the conversation can continue. Anybody else? So thank you so much, Peter, for that input. Can we hear from Mozambique? You raised a question, I think it was responded to, and you also have an interest to understand how this economic empowerment program is working. But we would also be very interested to hear how are things on your end. Do we have areas where you think we can have common messages and common issues to engage on? Over to you, Mozambique.
Bom, boa tarde mais uma vez. Não sei, com a permissão do colega Isidro, que acho que ainda está aqui também na reunião, mas eu posso fazer talvez um comentário rápido. Moçambique. Talvez, como dizia anteriormente, nós também temos ações que estamos a desenvolver para a redução de estigma e discriminação, porque também é uma realidade em Moçambique. E que agora também estamos no processo de elaboração do COP22, no âmbito do fundo do PEPFAR, e que houve uma grande discussão sobre ações inovadoras para a redução do estigma e discriminação. E a razão pela qual eu fiz a pergunta sobre autodiscriminação, porque é um dos grandes desafios que temos também para Moçambique, porque a questão da aceitação do ser o estado de muitos pacientes, em particular a população-chave, e também um atendimento amigável para esta população-chave em particular é um bocadinho, ainda é um desafio para Moçambique. E dizer também que há ações novas que para nós serão um aprendizado, que são ações estruturais, que para o nosso país ainda é uma novidade, porque não existe ainda, primeiro não temos uma diretriz sobre as ações do empoderamento das pessoas vivendo com HIV, em particular a população-chave. Seria uma experiência nova, talvez, se partilhassem conosco esta diretriz. Um outro aspecto aqui é a questão também da coincidência de algumas ações que são desenvolvidas em Moçambique, que são ações a nível comportamental e são ações também a nível biomédico, que de facto nós também temos várias ações que são desenvolvidas em Moçambique a nível das unidades sanitárias, como várias campanhas para a redução do estigma e discriminação, produção de manuais, brochuras e capacitação dos provedores de saúde. Estas são ações que mais são desenvolvidas em Moçambique, mas que ainda temos grandes desafios em autodiscriminação para a redução deste estigma e discriminação no próprio indivíduo. Então, se calhar são poucas coisas que talvez posso partilhar e dizer que ainda temos muito que aprender sobre o estigma, porque também é um desafio. Olhando para os dados por nós apresentados, ainda é um grande desafio para Moçambique. Obrigado.
Thank you so very much, Laurencio, for sharing your thoughts. I think you're right. The issue around stigma will still be a challenge for us. And we take heart in the fact that these conversations are happening and that we have tools which together we can utilize. The political commitment that was adopted by the UN General Assembly last June has set the 10-10-10 targets, which are critical for us to get to epidemic control and to end AIDS by 2030. So at least we have all the countries that have signed up to this and the guiding principles that will help us to engage on this. And we have also the opportunity through the SADC, EAC has been mentioned, but also through the AU to carry on these conversations. Colleagues, it's 4 o'clock. I think we want to bring this to a close. It's been interesting. It's not going to be the end of the conversation, but actually the beginning of the conversation. There has been a suggestion that South-to-South learning should bring us together again very soon so that we can discuss the way forward on sensitizing and learning. So as a closure, I want to hand it back to South-to-South learning for the closing and for guidance in terms of what are the next steps. But a very big thank you to Pendo, my co-chair, for the leadership, but most importantly to the presenters, Margaret, Damaris, and Mhando. You did a great job in sharing the experience of Tanzania, and for sure you have flown the Tanzanian flag very high. Thanks, colleagues who were able to listen in and to engage and contribute to asking questions and pointing issues that are of common interest to all of us. Margaret's quote, I think, is a nice summary for how we end this session, that everybody needs each other and everyone as we fight HIV. Asante sana, have a great evening, and over to you, South-to-South learning, for the closure.
Thank you, Team Tanzania, for taking us through the topic on addressing stigma and discrimination for key populations. Personally, I found the DSDM approach very interesting. And as you know, with all South-to-South Link and Learns, we would like to invite you to just participate in a very short 4-question poll to capture your thoughts on this Link and Learn session. The poll should be displayed on your screen in just a second. So while you select your answers, let me also say thank you for taking the time to join us in the session today. I hope that it was valuable to your own country setting and provided some interesting learnings. As with all Link and Learns, we'll be sharing the recording of the session, as well as the presentation to all the colleagues on the line. The SSLN is happy to facilitate any bilateral discussions. Simply reach out to the country representative or Kerry, and we will happily set that up for you. And lastly, just thank you all for this great session and have a great day.
So as we say in Tanzania, asante sana and kwaherini.
Asante, bye-bye.
Bye, thank you.
Thank you, bye.
Bye.
Bye-bye.
Thank you, bye.
Thank you.
Bye-bye.
Bye bye. Ciao, ciao.